Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hello again. Welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar from Rehab Practice Solutions. We are a leader in patient engagement and retention strategy. Basically, we help our clients attract, acquire, engage, and retain more patients. If you want to know more about that, you can head on over to www.rehabpracticesolutions.com/UPE. That's rehab, the letter U, practicesolutions.com/UPE. But enough about that. Let's dive into what we've got going on this week. This week, we are talking with Sarah Kitlowski, and she's the president and chief operating officer of a company called Omeza. And they're a biotech startup out of Sarasota, Florida. We're going to talk in this episode about value-based healthcare, but value-based healthcare in the space and in the realm of wound care and chronic wound care management. So her company developed basically a product that helps heal surgical wounds, skin ulcers, chronic ulcers, that sort of thing. And she talks a little bit about innovation in the health space. We talked about some of those canary in the coal mines where you see all of the data trending in, let's say, healthcare in general. There are decreased lengths of stay across the boards. There's decreased mortality rates, but there are some areas within the healthcare sector where the trends are going in a different direction. There's increased morbidity. There's increased odds and risks of negative outcomes or poor outcomes. And she talks about that being the canary in the coal mine. And that's how, when you see that trend in the data, that's where you really need to dig in and start finding out why. Why is everybody else or every other sector of healthcare experiencing gains while this one area or these several areas are experiencing sometimes losses, right? So we talk a little bit about that. We talk about the company Omeza and what they're doing, but we spent a good deal of time talking about payers and providers, all the stakeholders in healthcare, the patient, and how we can align all of these incentives so that what we end up getting is truly valuable healthcare that's valuable to the clinicians or the providers providing the services, to the payers that will be paying for the services, for the policymakers who are in charge of regulating and ensuring that everything goes smoothly, and ultimately for the patient who's the end recipient of that service in the form of better clinical outcomes and decreased mortality rates in the case of ulcers and chronic wounds, like decreasing the risk of amputations and the like. So without further ado, here is Sarah Kitlowski talking about value-based wound care. Well, hey Sarah, welcome to the show. How are you?
Good. How are you doing today?
I'm doing all right. Before we dive in to all the value piece of healthcare, for those that might not know you, might not be familiar with your work, kind of just give us a little background about yourself, about the company you're working with here, and what got you to what you're doing now, and then we'll kind of dive into wound care and that canary in the coal mine.
Sure. So my name's Sarah Kitlowski. Right now, I'm the president and chief operating officer of a biotech company out of Florida called Omeza. Omeza is a conjunction of amazing omega-3s. And so this company is specifically focused on addressing unresolved issues in chronic wound care and chronic skin care, which is a larger issue than people really think about. My background is in the intersection between marketing, business, and technology. That's what I was doing for a lot of years before I went back to business school. And it was when I was getting my MBA that I met the founders of this company, and what they were looking for was somebody who could bring innovation and energy to this product concept, this technology concept. So they scooped me up, and I became employee number one about 5 years ago. And we've since gone through a huge amount of growth, which is where we're at today.
Awesome. Cool deal. And when we were first talking before we recorded, you were talking about the canary in the coal mine. Why don't you explain that concept specifically as it relates to healthcare and value and innovation?
Sure. So when you look at the state of a lot of significant conditions, we can talk about chronic disease, for instance. People are living longer than they ever have and are able to live with chronic conditions. So something like breast cancer, which once upon a time had a very high mortality rate, was terrifying. And for some people was a death sentence. The mortality rate is very low. We have a lot of people who they can treat as a chronic condition. They continue to get checked. They may go through a couple courses of chemo, but it's not how it used to be. HIV and AIDS is another one where it's now considered a manageable chronic condition, albeit serious.
Yeah.
So folks are living longer. Folks are able to live with chronic conditions longer. More money is being spent in healthcare innovation, and yet the rate of amputations is rising. Why is that? Why is it that you can have somebody live with HIV or cancer for longer than ever possible, and yet as a country, and actually worldwide, there are more amputations, preventable amputations, than ever before? That's trending higher.
Yeah.
And so when we talk about a canary in the coal mine and healthcare in general, because that's just wound care, we look at what is an area where the data is trending in another way, where what seems to be a simple condition or something that is simple isn't tracking lower. And so our company is really focused on looking at, like I said, wound care and skin care. Why is that so different? But we also partner with other places in the industry where you see the same thing, where something that should be a survivable, overcomable condition is actually going in the other direction. So that's what we talk about, that statistic alone, that more people are likely to lose a toe below the ankle amputation, below the knee amputation, which if you have an amputation, your mortality rate at that point is actually higher than if you have cancer.
Yeah.
So that's kind of what I was alluding to.
Yeah. And then like one thing that pops into my mind too is like someone maybe has a manageable condition that for whatever reason it goes south, they get an amputation. Well, that just increases the cost of that individual's like level of care that they're going to have to receive now going forward, right? Like it puts an increased cost on the healthcare system and all of that. So why don't you talk a little bit about just kind of the cost of managing or mismanaging those chronic conditions that should be pretty, like you said, they should be pretty easy on the surface. They seem easy to handle, but it looks like we're not doing a good job of it. And it has big ramifications down the line, right?
Right. Because as you said, one condition begets another. So if you look at somebody who has let's say a diabetic foot ulcer, so there's already the cost of them managing diabetes, which you're looking at prescription costs and endocrinologists, primary care, and things like that, and then all of the ancillary conditions that come along with that. It's expensive on its own. But then when you throw in a diabetic foot ulcer, which gets treated too late, which is a lot of the reason why there is this huge cost. I think the last statistics from Centers for Medicare and Medicaid was just on the Medicare population, they're spending at least $28 billion a year managing just chronic wounds, just in their patients.
Holy smokes, yeah.
And that's, and one statistic I saw was that's when it was the primary thing. So when it's diabetic foot ulcer as a secondary to another condition, like vascular insufficiency or something else going on, it may not even be counted in that number. And it's a really difficult number to measure, partly because a lot of chronic wounds, people never actually go and get treatment for. And that's kind of this bigger equitable access, like what's valuable in the marketplace.
Yeah.
But yes, so a diabetic foot ulcer, which then leads to a partial toe amputation, which if not treated correctly, then leads to a full toe. At that point, then you have somebody who has some balance issues, mobility issues. There's the loss of work. There's the loss of, mobility and health and the decline there. Then you're potentially looking at a change in their circulatory system. So then you might have some like lower leg edema, and then your special shoes, and it's kind of this snowball effect where some set of the population, they have that happen, and all of a sudden they're empowered. Like they have this, like, this will be the last time it happens, it will be no more. What we find though is sometimes that's a matter of like what physician is on the other side of it and how much hope they're giving them, as opposed to the other side where there is unfortunately part of the population that says, hey, people who are getting amputations, particularly if it's a result of diabetes, that's from lifestyle choices. And so you wouldn't have had this happen if you had made better choices. And so there isn't this necessarily hope given to the patient, which then leads to the cycle of all of these other things. I mean, if you get an amputation, you're way more likely to get another amputation.
Yeah. No, it's interesting that you bring that up. I was talking to a few friends of mine the other day who are PAs, and one of them works in nephrology, and he was talking about diabetes, and he, managing a patient, just a difficult patient that he has. And he said, yeah, they call it the disease of non-compliance. And it's like, well, if you have this, like, that's the culture, or at least the idea in the healthcare field, like these clinicians are looking at these patients as it's something, and that there's personal responsibility, let's get that out there. But like, when the message is you need to do a better job, like it can't breed hope, right?
Right. So who can do something about that? Who decides that? Because what you've pointed to isn't in the solution. So if we say we have a problem based on non-compliance, who can do something about that? You have physicians who say, I tried. Education, social workers will give them education. And then the tech people, apps. We need apps, we need telehealth. You see all this money flowing into telehealth, telemedicine, remote monitoring, and all of that. That's great. But what might, and I will take the case and say is missing is products designed to meet patients at their acceptable level of compliance. Yeah. So I'm gonna use an example from another industry, and it's because one of the board members in my company is responsible for this in the consumer products industry, and I'll keep the brand name out. But once upon a time, it was a pain to mop your floor, right? You had to get a mop and a bucket of water and soap, and then all of your floor would be wet for a while, and all of that. And so you could say that people whose floors, their kitchen floors, may have dog hair or were dirty, were non-compliant. They were not compliant with using mops. However, the game changer in that wasn't a public health campaign. It wasn't an app to remind people every day. It wasn't people coming over and saying your bad lifestyle choices. It was, hey, what if we have disposable mop heads that are super cheap? You go buy already wet, already soaked up pads. You put it on, your floor dries quickly. All of a sudden, you have a product that is so user-friendly, it induces compliance. And so when you talk about, like, we can continue this conversation of like who's to blame and all of that, but part of the solution is creating a solution that induces compliance. We see that in other areas of medicine as well.
Yeah. Well, and it almost kind of gets to that aspect. I know you've talked about value, and we talked about value a little bit earlier, like we'll get into it, but it almost kind of starts working into that level, right? Like subscription models in other places are valuable to the user, and that's why they're taking off and people buy it and they use it. And so you're almost kind of working into that, like taking a value-based approach to healthcare from the patient's perspective, right? Like this is actually going to be valuable to the patient because information about what they're doing or what they're not doing and the lifestyle changes they need to make doesn't really help them, right? Like what helps them is something that meets them where they're at, wherever they are on that road to recovery and whole health. So let's talk a little bit then about that value. Like what's keeping us from doing that as an industry, and specifically in healthcare? Like, what's keeping that innovation from happening?
I'd say sometimes it's misaligned incentives, and it's incentives in payer medical policy or healthcare system policy, or theory of value-based organizations or GPOs, like all of these different layers that are involved in the decisions around healthcare that we will pretend aren't practicing medicine, and yet are the rules of the road and the bumpers saying we're not practicing medicine, that we still leave that for doctors as long as they're practicing medicine, as in it gets paid for within these limitations. And so you have sometimes decisions that are made, I think, with good intentions. And I'll say that I, despite my loud advocacy, I hold the payers close. I spend a lot of time talking to, folks who run large insurance companies, because they're not like the enemy either. Good innovation and value, real value, it holds value for all three key people in healthcare: the patient, who is the recipient, but not ultimately like the customer; the physician, who is the decider to some degree; and then whoever is paying the bill, whether that's CMS and Medicare and Medicaid, or it's private insurance, or some other version of that. So, but if you're incentivizing the patient by simply like, you might feel better, maybe not, or you won't get in trouble, or it won't get worse. So like, there really isn't a lot of incentive for the patient other than like, make the hurting stop, but only to the degree that I can manage it with the other things in my life. Like, make the hurting stop to the amount that I can afford it, or make the hurting stop to the amount that I can actually take off of work to go to the doctor. Make the hurting stop to the level that like I understand and I feel safe. So that's their kind of incentive. And then you have the physician, which on the one hand is absolutely, I want to do the best I can for the patient. However, I can't lose money and go out of business because
then
I want to do a treatment, but it's not, there's no reimbursement, or I am getting paid, which is where we're at right now. I'm getting paid when people stay sick. And I'm not saying that there are doctors who are keeping people sick, but like, I just because my world is wound care, I know that a lot of physicians, the bills are paid and the lights are on, which is smart business based on debridement. So a wound dressing change in some areas, like the actual, I'm just going to change the dressing, which needs to be done, isn't like fully reimbursed, but they are reimbursed if there's any debridement that happens. So you have kind of this incentive for them to keep cutting, even if maybe they don't need to, or, other types where you have like super really expensive therapies, which means that again, the doctor can then pay for other areas that are loss leaders. So you have those incentives. And then you have the payers. Their incentive is, what is the best decisions we can make to keep this entire population healthy, which is based on statistics and most likely and all of that. And a lot of times they are slow to keep up with the value proposition of new technology, because they spent a lot of time making some really good decision 15, 20 years ago based on some major clinical trial, set that in stone, and then it's never to be touched or revisited again until something major happens, which is how wound care is at. I mean, most payer medical policy looks exactly the same, and it's based on clinical trials that came out about 20 years ago.
Yeah. Well, I think that's a good outline. Like your description of kind of the patient, the doctor, and the payer, what they're going through is like a good description and a good visual for the fact that value is different depending on where you're at in the chain, right? Like what is valuable to the doctor is going to be different than what's valuable to the patient. What's valuable to the payer oftentimes is that efficiency, that cost reduction, like keeping the most people healthy for the least amount of money, right? And it's very easy, like I'm a clinician as well, like it's very easy to look at the payers and be like, well, those payers are what's wrong with healthcare because they're just cutting reimbursements. It's making us not be able to see these people, yada, yada, yada. They're not approving visits. And it's just a lot of that comes from the fact that we just don't understand, or we're not putting ourselves in their feet when it comes to the value proposition for them versus what is the value proposition for providers or for patients, right?
Yeah, yeah, for sure. Because they will say that they are protecting physicians and patients from like um, from potential ineffective innovation, and some of that is, you know, like being burned a couple of times by being promised like this is the greatest innovation since, and you know, and they will allow something which then after watching it, it's like the outcomes are not what they measure. The outcomes aren't any better than, you know, the control group and standard of care, but you have, you know, skewed biostatistics, and then they get kind of gun shy about adopting innovation, or they, you know, you see a lot of companies that are now more hesitant to embrace tech in certain areas because everybody spent all of this money updating, you know, we're going to fully integrate electronic medical records and all of the doctors are going to have apps. And then now you look at the efficiency of workflow, and doctors, clinicians and nurses are spending more time like on this app and on this screen and all that than practicing medicine. And so it's kind of this pendulum swing.
Yeah. Yeah, that's a so when they went to EMRs, everyone was like, oh, it's going to be so much more efficient.
Yeah.
And it ends up not being efficient, right?
Yeah, I mean, and is it or isn't it? It kind of depends on the system you're in and how well integrated it is, and you know, all of that. I will say though, you know, like I said, I met with over the last quarter with two former like retired heads of like a chief medical officer from one of the larger payer systems, and I will say that they take personally any challenge that they don't care about patients. It's really about, and that I, you know, I've been somebody that I've maybe spoken out of turn and treated them as like some big anonymous entity, because when I read what's allowed in payer medical policy, I read that anonymously and I'm like, how can you say that waiting, you know, for me, I get riled up because a lot of times chronic wound patients, they need to have on paper documented that they're not healing for 30 days. It's not enough for them to walk into an office and say, I've had a venous stasis ulcer for 6 months. There is like, well, we're going to go ahead and wait for another 30, 45, 60 days to make sure it's not going to heal. I'm like, if you go into a primary care and like, I've had sinus infection symptoms for a week, they're not like, you know what, we're going to write it down, come back in a week. We want to make sure you're still sick, right? I mean, but that's based on another meta-analysis and clinical trials and all of that. But from the payer perspective, it's really about like, we are trying to make the best decision for 50 million lives. And so it's based upon statistics, and folks come with us and you know, are in pitching this and pitching that all of the time. It's that we want to move slowly and carefully to make the best decision possible, because we know our decisions do affect 50 million lives. So I'm not taking them off the hook by any means, but it in the same way that working with the FDA humanizes them, working with payers humanizes them. And sometimes I think the responsibility of those who feel like they're not being served correctly by the payer is to get better at communicating.
Yeah. I think that's a big piece that's missed out of the conversation, right? Like, it's easy to rail against any one of the players in healthcare, policymakers or the payer or whatever. But unless you're in there advocating and working with them and actually doing the day-to-day, you're just always kind of talking about the man behind the curtain almost, right?
Yeah, exactly.
Yeah. So you mentioned tech, you mentioned all this money that's recently been thrown at apps and remote patient monitoring and all of that kind of stuff. Like, and I've even consulted for some companies that are healthcare tech, you know, like startups. They're trying to get in there and they want to make a big impact in the world for the patients that they're serving, or the providers that they're providing a solution for. But I get the hint from what you're saying that might not be money well spent, or is it money well spent? We're just not utilizing it well. Like, what's the big problem with all the money getting dumped into technology and telehealth? And is it really valuable? Are we utilizing it correctly or not? And kind of just talk about that for a minute.
I will say, there's no doubt in my mind that telehealth, telemedicine, I'll stick with that, which is, the ability for a physician or a clinician to interact with the patient without the patient leaving the home. That is one of the greatest things that could happen to medicine. And unfortunately, it took COVID for it to really be fully embraced and tested out. But if you look at the amount of people who are still using that afterwards, and the ability for patients who didn't have that beforehand. I mean, you look at the money in the VA and in IHS and tribal health that is now being dedicated to ensure that rural communities they were looking at driving 2 hours just to get somebody beyond whoever the local primary care was. Like, their ability to interact with a physician and a clinician is huge. That's going to make a big difference. My call out is that needs to be paired with therapies that also work for a patient. And so if you're only using telehealth in order to talk to people at home, but then that is resulting in saying, okay, we are sure that you now need to come into the office once a week, every week for 5 months, 6 months, or every day, or, all of that. If we're not matching, and that's on my industry, med device and pharma and all of that, if we're not matching it, then like, that's great. Like, the telehealth needs to be paired with therapies. It's interesting. One of the early ones that got moved to the home was sleep apnea. Once upon a time, sleep apnea and sleep studies happened in the center, and people would go in and sleep and get monitored and all of that. And this is, I think it was 10 years ago that they really started adopting doing sleep studies at home. And at the first it was like, well, you can't do that. It's not a controlled environment. But we trust patients to do very complicated things at home. I mean, for a long time, diabetics were doing their, before you had pumps, they were doing injections. People do ostomy bag changes. They recover from major surgery at home. If we can trust them in all of these other areas of medicine to self-advocate and speak up, all of these other areas of telehealth need to come with product innovation.
Yeah.
That's really what I'm calling out, is that it's only half the battle. Because if you're looking at an area of medicine which could also be maybe moved at home, but you're not, then you're just spying on patients.
Yeah. That's a good way to put it, right? My dad was talking to me the other day about, so he's got an Apple, one of the Apple Watches or whatever, and his insurance company just sent him an email that says, oh, we noticed you have an Apple Watch. Do you want to connect it to our system or whatever, and we can monitor you and help you improve your health or whatever? And he was like, no.
Right.
Thanks, but no thanks. I'm good.
Yeah. I get it. I have a Fitbit, and if they said, like, my Fitbit, I love it because it will say, we're concerned you haven't slept enough this month. But like, the last thing I want is my insurance company to know that about me. They would change my risk profile for sure.
Yeah. All right. So we've talked about the tech, we've talked about the value, kind of all of that kind of thing. So let's talk then about those, like, that innovation, bringing it to those areas where there are those outcomes that are reversed, or they're trending the wrong way that we would like to. Like, let's talk a little bit about how we do that. Do we do that over tiny incremental, like, improvements over the paradigm that's there, or do we try to move more for those big game changer technological or even pharmaceutical advancements? Even, like, how do we best make change for those areas where the rest of the outcomes are trending upwards, but this one area is trending down?
I come from a go big or go home. I mean, I think that, incremental changes are appropriate when we are looking to see what works at those kind of alpha beta tests. I come from tech, so of course I'm going to say that. But when we're looking at what therapies hold weight and what the patient experiences, but when you look at other earlier areas that had kind of a revolution, it involved a big game changer. And sometimes the game changer, I mean, usually it's a combination of a product, a drug, a device, and a change in the care pathway. So let's take smoking as an example. We had incremental improvements for a long time, but they weren't significant. they weren't a large majority. I mean, the science came out and people started understanding, generations grew up and all of that. But if you look at huge drops in the numbers, it came around the time that Zyban came to the market. And also all of the smoking cessation programs became free and encouraged, as opposed to, like, we changed from the environment of don't ever tell somebody that you are a smoker to please. I mean, you would have insurance companies and employee wellness programs and EMP or EAPs incentivizing people to self-disclose, and then fully covered people were given pharmaceuticals and gum patches, all of these things. It was like, we're going to throw all of these resources at the problem. And from the insurance perspective, all of a sudden it was the recognition of lung cancer is freaking expensive. Yeah. It is far cheaper for us to give away all of these things for free. I mean, if you disclose to an insurance company, I am a smoker and I want to quit, they will say, how much stuff can we send to you for your house? No copay. No, I mean, most of them, they will fully fund whatever it takes you to quit smoking. And so that, I mean, part of that was, drugs and devices, but part of it was the desire, the medical policy change, the incentives changed, and they kind of all had to come together at the same time.
Yeah. So you're looking at kind of how do we align it for all of those people, right? Again, those P's, right? The payer, the provider, and the patient. How do we make it all line up together? Yeah. Can that be done through like a focus group is such a bad word, but like, let's say we've got something we want to bring to the market to improve these outcomes. Like, what's the best way to do that? Do we have to tackle like each of these pillars, if you would, one by one, or like, what have you seen work in that? Like, obviously the smoking one was huge. So like, how do we replicate that?
I can speak from my own company's experience, which is it's resisting the urge to polarize or demonize any major player in it. Uh-huh. It's not treating innovation in medicine like a team sport, like us versus them, and being able to willing to sit with people who, again, you may think that they have misaligned incentives, but before that, it's understanding really like what's going on and why are things the way that they are. It's, kind of becoming an anthropologist in this area and really pulling the pieces. And it can be nerdy work, but payer medical policy actually is a great archive as to how a certain area of medicine got the way it did, because it's gonna talk about, hey, how did the elephant or the big guy, the giant in the room, which is CMS, how did they decide their coverage thing, which a lot of payers, they will decide based on their population. Like, they decided that, and that comes with like, well, that was decided because they saw these studies in this study, and they saw these statistics and that statistics, and this is how old it was. Like, this was the last time a meta-analysis of, or like a meta, RCT was done. And so you kind of have to look at all of those things for sure. And then of course, there's always a lot of value in sitting and talking with patients who are affected. And you can kind of pull apart their experience and start to see what's wrong based on like what happened to them, and treating those symptoms as clues, treating their experience as clues, whether you're looking at like a recurrence or a loss in some other area, or like the kind of quality of life things that are kind of tacked on at the end of like, oh, also, how does the patient feel? Yeah. That's gold. Because to go back to what you're talking about, true value helps payers spend less but help more people, helps physicians do better medicine because they want to and they see good outcomes, not because of some dollar amount associated, and ultimately helps patients feel good about their treatment and their outcome. That's value when you're doing all three of them.
Okay. Yes, that's wonderful. Well, we're getting near the end here. I always ask this question. So if there's one or two main points that you want a listener to walk away from the show with, what would they be?
I think advocating for your ability to use innovation in your own medicine, like from a patient. I do think too that there's a lot of interesting places where people can start making their own decisions and are covered. But really it's about continuing to advocate, learn, get information. I mean, again, payers are not as hard to reach as need be, but that's secondary. When it comes to my world, which is the world of healthcare innovation, it's continuing to challenge. The changes come because people say, all right, enough is enough. Enough is enough. We need to move forward and do better in this area. It's great that a lot of dollars are being spent in healthcare and innovation. That's great. I mean, we all want cool apps on our phone, but if that money in tech and all of that can be spent in helping us be healthy for longer. So I think the demand for innovation in home healthcare, not home health, but healthcare that allows us to stay healthy at home, continuing to say, that's what we need, that's what we need, that's what we need. We've done that in so many other areas. I can get chicken wings at 2 a.m. delivered to my house. I didn't even ask for that.
Yeah.
Right. But like chemotherapy is now a pill because of advocacy. That is huge.
Yeah.
And so people saying, you know what, dollars in the market and my insurance money and wherever my, investments are going, keep me healthy at my house. That is huge. That's where I would hope people would continue to aim for. Like, yep, I want to know that the tools that have been developed to make my life great in all of these areas, that absolutely they're also being applied to medicine.
Yeah, awesome. Well, Sarah, thanks so much for taking the time. Before we get out of here, where can people find out more about you, about your work, about Omeza, any of that? Just all the places where people can find you.
So you can always find me on LinkedIn, LinkedIn/Sarah Kitlowski. It's a great last name, but I'm sure you can find it in the show notes. My company is Omeza, OMEZA. You can find us at omeza.com, or if you're a physician and want to learn more, we're at omezapro.com. Those are really the best places to find me and my company. You can find me on YouTube too, of course. But I would encourage people to reach out to me, and you can always email me directly, sarah@omeza.com. And if you want to talk about innovation in healthcare or wound care, biofilm, I love talking about that kind of stuff too.
Awesome. Well, thanks, Sarah. Have a good one.
Thank you very much.
Well, I hope you enjoyed that conversation with Sarah Kitlowski about innovation in healthcare, about wound care, about just aligning all of the incentives, right? Or all of the value pieces in healthcare. Particularly in the US, we've got 4 stakeholders at any given time. You've got, we call them the 4 Ps of healthcare, right? You got the payer, the provider, the patient, and the policymaker. I was recently consulting with a company coming out of the UK, and they're trying to make a entrance into the US healthcare market, and they come from a totally different standpoint, right? They've got a single payer system for the most part. Their policymaker and their payer tend to be the same person a lot of times. So getting their heads around like, no, listen, we've got 4 different stakeholders that we're trying to speak to, and the way you approach each of them needs to be different because they're each valuing something different in that equation. One is more worried about long-term outcomes. One is worried about cost. The patient ultimately is worried about whether or not this is going to solve my problem or not. So it's always an interesting dynamic when you're talking about bringing a new product to the market, especially in healthcare, or trying an innovative approach to treatment, because you're not just dealing with the A and B, like the patient and the provider, but there are these other stakeholders in the mix that need to be satisfied as well. In fact, coming up in a few episodes, I'm going to have Ron Baker and Ed Kless from the Soul of Enterprise podcast. I don't know if you're familiar with any of their work, but Ron has written a couple books on value pricing, on how to move away from a fee-for-service model to sort of a fixed rate or a rate that is based off the value or the outcomes that are going to be provided. Now, he's an accountant. He's not in the healthcare field, but the idea translates very well. And we're going to be talking a lot about the third-party payer system, kind of the misaligned incentives when other stakeholders get involved, and what clinicians and healthcare organizations can do and are doing in the space to kind of remove some of those constraints and make healthcare more, again, about the relationship between the patient and the provider or the organization. So look forward to seeing that in a few episodes. If you like the show, head on over to iTunes, leave us a rating and review. It helps people find us, and it means a lot. I like seeing them reviews when they come across. Or if you have questions, shoot us an email at support@rehabupracticesolutions.com. That's support@rehabpracticesolutions.com. Any questions or suggestions for another episode, or maybe even a guest you've got that you want us to have on the show, that would be great. And if you are a healthcare administrator, a clinic owner, someone that's up in the echelons of a healthcare organization, and you're looking for a way to really make healthcare more human, to remove some of those abstractions and barriers that prevent a real meaningful relationship being formed between the organization or your providers and the patients that are being seen in your facilities, then I'd encourage you to head on over to the Ultimate Patient Experience Blueprint and learn a little bit about what we do at Rehab U Practice Solutions and how we can help your organization really return the focus of healthcare to where it should be, and that is ultimately the people that both run our organizations and work in our organizations, as well as the people whom we serve. And you can find out more about that by heading on over to www.rehabupracticesolutions.com/UPE. That's rehabupracticesolutions.com/UPE. That's all I've got this week. Until next time, everyone, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabupracticesolutions.com. We'll catch you on the next episode.